classroom right now.
Sweet. Well, thank you for the kind introduction. I didn't hear a word of it because all of our residents that were in the room just ran out for a code blue, and so it was a big auditorium. It's completely empty, and it's just me. And for some reason, my audio isn't really working, so I couldn't even hear you. So hopefully, you can hear me, and there's still some learning points. I definitely welcome people putting up their hands and asking questions, putting them in the chat. I don't actually see a chat here on this call, but feel free to pop your hand up at any time and stop me. My hope today is to outline an approach to assessing a patient with shock that hopefully is holistic and encompasses some terms and hopefully a little bit controversial and maybe questions some of the traditional dogma in the resuscitation field. So let's start with a patient here. So a patient who has septic shock, possible pneumonia here. They've received a few liters of fluid in the emergency department. They're a bit hypotensive. And now we have to make a decision. Do we continue to give them a little bit more fluid resuscitation or do we start them on vasopressors? This is something that we encounter quite literally every day in the intensive care unit. And hopefully I can show you my approach to thinking about a patient like this. But before we kind of dive in deep and talk about hemodynamics, I really just want to level set on IV fluids here. And really what we're talking about is salt water. And I always just think that if I became critically ill and ended up with septic shock and I was driving to the emergency department, but instead of going to the emergency department, I went to a naturopath because there was a naturopath right next to the emergency department. And I roll into the naturopath and they say, Ross, like, you're dying of septic shock right now, but I have the perfect solution for you. I'm going to take 8 tablespoons of salt, put it in a liter of water and inject it into you. And that's going to cure it. But if I do 1 liter, you're going to die. But if I do 2 liters or 3 liters, you're going to survive. I mean, you'd think that they're a complete nut job and you drive right past them and go to the emergency department. Yet Baxter has us fooled. And I think Baxter has done a really, really good job kind of dressing up IV fluids into something that perhaps they're not. At the end of the day, they're just salt water. I think from early, even before medical school, we're indoctrinated to view IV fluids as this mystical kind of thing. I mean, every TV show shows what happens when the cardiac arrest rolls and somebody's squeezing the IV bag of fluid like it's a lifeline, a life preserver. And so I just want to throw it out there that at the end of the day, when we talk about fluid resuscitation, we're talking about salt water. We all know that salt water is not the cure for septic shock. And there are times where certainly saltwater resuscitation is appropriate, but there's also times where we have to be thinking kind of beyond that. And hopefully I can communicate how I think about this a little bit. And so we're going to go through some terminology here. Volume status. So volume status seems like a very precise thing because when we're in training, the attending walks around, they hold up their finger and they're like, oh yes, this patient's a little bit dry. Truthfully, I think it's really just a way of communicating, do you want to give more fluids or more Lasix? And I'm going to go through a little bit about why the term volume is actually a little bit misleading. And it actually isn't about the volume as much as how that volume is interplaying within the circulation. And to start, we have to understand that our circulation kind of can be thought of as having 2 components. And this is like Newtonian physiology, but hopefully not to the point that it bores everyone. And the idea is that we have a stress compartment and an unstressed compartment in our body. And most of the blood sits in this low pressure, unstressed volume. And these are often venous capacitance vessels, things like our splanchnic circulation. And they're not actively participating kind of in the circulation as much. And then about 30% of the blood volume fits in the stressed volume. And this is the part that we can manipulate through fluids, through vasopressors, for example. It turns out that what drives venous return is not just the total blood volume, it's typically the blood volume in the stress compartment. So when we give somebody IV fluids, we want to increase the volume in the stress compartment to drive more venous return. But as I'm going to show you, that doesn't always happen. So what actually drives venous return? And it's this concept of mean systemic filling pressure, right? MSP. And mean systemic filling pressure could roughly be thought about if I had a cardiac arrest in this room and everyone's so bored that they decide not to do CPR on me and they just let me fibrillate on the ground for like 20 minutes. And then one of the residents who has an EPA to complete does an art line on me. And so they insert an arterial line when I'm dead. What's my blood pressure? It's not 0. And so sometimes people think that, oh, well, your blood pressure when you're dead would be 0. It's actually not. There's still a pressure inside the blood vessels. And that pressure is generated by 2 things, the amount of blood in the vessels and the tone of the vessels. And that's your mean systemic filling pressure. And similar to a water balloon, if you have water inside a water balloon, how much pressure is on that water depends on how tight the water balloon is, and also what the water balloon's made out of. If you have a really like thick, like basketball kind of substance, and you fill it up with a lot of water, it would be under higher pressure than if you have a really compliant venous system or a compliant container. And so really, mean systemic filling pressure, or what drives venous return, depends on two things: how much volume you have in the stressed compartment, but also the compliance of the venous system. I'll just put that there. But there's one other variable we have to consider, and this is the downstream pressure at which, against which the mean systemic filling pressure pushes. This can be thought of as the right atrial pressure. And so it's the difference between mean systemic filling pressure and right atrial pressure that drives venous returns. So when we talk about fluid resuscitation for patients, our hope is that when we give somebody a fluid bolus, it is going to go into their vein, it'll actually go into their stressed compartment. Inside that stressed compartment, the mean systemic filling pressure will increase, and that mean systemic filling pressure will increase relative to the right atrium, and then will increase venous return. But it turns out this doesn't always happen for a couple reasons. First, when somebody has vascular permeability and vasoplegia, a lot of the volume that we give them doesn't actually go into the stressed compartment. Also, we can accomplish the same thing by giving somebody a vasopressor sometimes, where actually the vasopressor itself will kind of squeeze more, increase mean systemic filling pressure, and increase venous return. So even if fluids will increase venous return, it may not be the only way to increase venous return. All right. This is where this term kind of hypovolemic shock can sometimes get us into a little bit of trouble, because when somebody's bleeding to death, of course, the treatment is give them more blood. But there's a lot of patients who have very, very slit-like IVCs, and the initial instinct we might have is, all right, we need to fill them up with fluid because their IVCs like really, really collapsed. I try to think about these patients as not just hypovolemic, but as patients who have low mean systemic filling pressure. And that could be one of two things. It could be the volume in their stress compartment, absolutely, but it could also just be that they're very vasodilated. And that can also drive low venous return. All right, so what then is fluid responsiveness? And I'm going through these terms very deliberately because sometimes people throw out these terms interchangeably, but they actually have very precise definitions kind of in the hemodynamic world. And so fluid responsiveness can roughly be thought of: will a bolus of fluid, typically 500 mils in the literature, increase your stroke volume or cardiac output, depending on which study, by about 10 to 15%. Now, preload responsiveness is a similar concept where would a bolus of preload, for example, a passive leg raise, increase your cardiac output by 10 or 15%. So I'll just kind of put that there. There's a lot of different ways to actually calculate this. Now, there's an emerging concept in the fluid resuscitation literature of fluid tolerance. And the idea of this is that, yes, fluids absolutely can be beneficial. They can increase your cardiac output, they can increase perfusion. There's also potential harms. And so fluid tolerance is a holistic concept of adding up the potential harms of IV fluids. And there are macrocirculatory harms, so patients become edematous and can't mobilize. They can develop abdominal compartment syndrome, pleural effusions, pulmonary edema. But there's also potential microcirculatory complications. For example, fluid overload is associated with potential abnormalities in the glycocalyx and capillaries, and actually may precipitate further capillary leak. And Dr. Van Nienten, one of our clinical scholars here in London, has done some really interesting work demonstrating that there's higher rates of endothelial dysfunction in patients who have congestive organ injury compared with patients who don't. And then also it can cause congestion at a capillary level here. And so this is fluid tolerance. And I typically think of fluid tolerance with a few different domains. The acute illness that you come into the hospital with or that you're presenting with makes you more or less fluid tolerant. So a patient who has already abdominal compartment syndrome or pancreatitis may be less fluid tolerant. Somebody who comes in with acute heart failure, of course, they're very fluid intolerant, and we wouldn't even think of giving them fluids as part of their initial resuscitation. Somebody's chronic diseases could also make them less fluid tolerant. So think about patients who come into the emergency department with end-stage renal disease, and we're trying to hum and haw, should we give them fluids? How much fluid should we give them? Because we know that they're at high risk of volume overload and pulmonary edema, so that would be less fluid intolerant. Or patients with an EF of 5%. I don't know about you guys, but when I see a patient who has an EF of 5 to 10% and they come in with sepsis, I'm thinking, gosh, I don't want to give them too much fluids, otherwise they're going to go into pulmonary edema. And so the concept of fluid tolerance, I think, is actually in the back of our mind, but hopefully this gives a term to think about the potential harms of IV fluids. And of course, congestion, which I'll talk about a little bit more. All right, a couple more terms and then we're going to put it together here. So venous congestion. Venous congestion is a phenomenon that can happen on the left side of the circulation. We see that with pulmonary edema, for example, or the right side of the circulation, where high pressures will actually go backwards into our organs and cause damage. And there's a lot of different ways to assess for this. You can use CVP, you can use fancy scores like the VEXA score that we'll talk about a little bit. You can use carotid or jugular Doppler. All of these work, but patients with venous congestion may be more harmed by IV fluids, so this is part of assessing for fluid tolerance. And then the last thing, volume overload, which is different than venous congestion because you can have a patient with volume overload who has edema everywhere. They have peripheral edema, pleural effusions, they have ascites, but they actually have no venous congestion. Perhaps they're just very leaky capillaries. And you can have a patient with severe venous congestion with no overload. Maybe they have acute RV failure, they have a pericardial effusion, for example. All right, so that was a lot. Any kind of preliminary questions here? And then I'm going to go on, how do we actually start putting this together?
I'll just add that we have the Q&A function rather than a chat function here. So if there are any questions, please put them in there and Eric and I will monitor and let Dr. Prager know.
Excellent. Thank you, Anton. All right. So when I approach a patient with shock that I'm trying to decide, do I need to do something to improve their perfusion in some way? Maybe they're hypotensive, maybe they have high lactate, maybe they have mottled, maybe they have organ failure. For whatever reason, this is my approach. I start with the microcirculation. I then ask, are they fluid tolerant? And then I think about macrocirculatory parameters that I can optimize. At the microcirculatory level, these are some of the things that we're going to explore. The fluid tolerance, we already talked about the different components that'll go into that, and we'll dive in a bit more. And then at the macrocirculatory, we'll explore things like fluid responsiveness, kind of RV-LV function, cardiac output, inotrope responsiveness, and go from there. So this is actually not the microcirculation. This is just like an animation I found online. So please don't, this is not actually red blood cells here. But why do we care about the microcirculation? And I want to just maybe think about all of us right now listening to this. So all of us right now, if we hold a mirror onto ourselves, which is what this ChatGPT generated image is meant to convey, but if you hold a mirror onto yourself, all of us right now are fluid responsive because fluid responsiveness is a normal, healthy physiologic state. All of us are fluid tolerant. You could give us 5 liters of fluid and we're probably all going to be fine. None of us right now are hooked up to IV fluids and none of us need IV fluid resuscitation. Well, why? Because none of us have microcirculatory dysfunction. When we talk about shock, we talk about impaired tissue level oxygen delivery. Really, it comes down to the microcirculation. It's not a blood pressure. It's not cardiac output. It's the impact of that on the actual tissue that we care about. And that is a microcirculatory phenomenon. And so there's a lot of different surrogates you can use to assess for the microcirculation. Because unless you're doing this in a research capacity and you have dark field or sublingual microscopy, we cannot actually visualize the capillary flow through tissues. So we rely on surrogates that are easily available for us in the ICU to make those decisions. Capillary refill time is my favorite, and we're going to talk a little bit more about that. But really, we shouldn't just be looking at one thing. We should be looking at things holistically. So things like modeling, things like lactate, things like urine output. You could add more of these pulse ox pleth characteristics, skin temperature even. All of these could be surrogates of microcirculatory function. And the reason why I like cap refill is because it probably has the best evidence base to guide resuscitation out of all the different strategies. And the idea is if you hold gentle pressure on the nail bed for 10 seconds and then release it just to the point that you see blanching, that is actually a pretty good surrogate of what's happening at other organ and tissue beds around your body. And the thing that is really nice about cap refill time, unlike lactate, unlike modeling, is that it responds very quickly to hemodynamic interventions, within minutes, in fact. And so if you have a patient with poor cap refill and you do an intervention like give them a fluid bolus, start an inotrope, you can actually see the response within 5 or 10 minutes, instead of having to wait for hours for the lactate to clear, or sometimes minutes to hours for things like modeling to start improving. And so this was the basis of Andromeda Shock, which was an RCT that was published in 2019 in JAMA that compared patients with lactate-guided resuscitation compared with just kind of standard, cap refill-guided resuscitation to lactate-guided resuscitation. And it showed that there was certainly a trend towards improved mortality and improved outcomes for patients that we use cap refill-guided resuscitation instead of lactate. For similar reasons that I just talked about, it's more instantaneous. And so this culminated with Andromeda Shock 2, which was published in 2025. And so this demonstrated essentially that using cap refill guided resuscitation for patients with septic shock likely improves outcomes compared with patients that had standard resuscitation care. It was over 100 centers worldwide, and John Basmagi and myself were lucky to be collaborators on this study. But what it really showed was that if you use cap refill guided resuscitation, you can do an intervention, reassess your cap refill. If it gets better, don't do anything else because you can't get better than normal. But if it's still abnormal, there's more and more things to try. And so that's what I really, really like about this study is it says, all right, start off and just ask, does this patient have normal cap refill? If the cap refill is normal to start, do nothing else, just reassess in 30 minutes. If it's abnormal though, all right, now let's start figuring out why. Is the patient vasoplegic? Are they fluid responsive? Do they have cardiac dysfunction? And then once you've identified something that might be wrong, do an intervention and reassess 30 minutes later. Don't wait 6 hours to see whether or not the patient's getting better. We can use this as a real-time kind of resuscitation guider. And that was something that was great. This was a great, well-done study, and I think really supports the use of this kind of microcirculatory first approach. The actual interventions you do and how you assess for fluid responsiveness, that's really up to all of us. And we may have a different approach than the investigators in this. But the idea that by starting at microcirculation, we can improve outcomes, I think holds true. Modeling is another great kind of tool. So patients who have modeling have worse outcomes. Patients whose modeling gets worse have worse outcomes. Patients whose modeling improves have better outcomes. So when I see modeling, to me, that's a cue that there's something wrong with the microcirculation and we need to figure that out sooner than later. Now, lactate is also a marker of potential microcirculatory dysfunction, but it comes with a caveat. And the caveat is that a lot of lactate production in critical care is not actually due to tissue hypoxia. That's what we're taught kind of in our undergrad biochem classes, that it's anaerobic respiration. But actually most, and this has been supported now across multiple studies, most lactate production in the ICU is due to aerobic lactate production from essentially epinephrine, because epinephrine stimulates adenylyl cyclase, it produces lactate as part of a normal process. And in fact, patients, and we see this all the time with Ventolin, for example, but patients who have a lactate response to epinephrine. So if you give somebody epinephrine and their lactate goes up, actually have better outcomes than patients whose lactates don't respond to it in septic shock, suggesting that they actually still have intact aerobic kind of respiration and aerobic energy production, as opposed to patients who have completely lost the ability to generate that. So all that to say, lactate can be a useful thing, and it's certainly something that I think about as part of my resuscitation, but I prefer more real-time surrogates and microcirculation as opposed to just using lactate. And so there's this thing that people have termed the lactate bolus reflex, where the lactate goes up and what do? We order a fluid bolus. I would encourage us to maybe rethink that a little bit and focus on, is there source control? And do we have the right shock etiology? And what we know is that septic shock is a cause of shock, but it's not a phenotype of shock. So the idea that septic shock is distributed shock actually isn't always true. And that patients with septic shock, when you look at their hemodynamic phenotypes, many of them have RV failure, LV failure, BIV failure, dynamic LVOT obstruction. And so really, I like to think, all right, I have a patient with septic shock, their lactate is going up. Is there source control? And does this patient have some other etiology of shock that I'm not anticipating? For example, commonly RV failure. And in really sick patients with septic shock, about 20 to 30% of patients can have RV failure. All right. The last concept I'll talk about, and this is kind of a newer concept, so I'll kind of keep it a little bit on the briefer, but this is kind of the cutting edge and something that we're thinking about right now and doing some research into, is hemodynamic coherence. So we assume that patients who have really bad cap refill and modeling, who have really bad microcirculation, if we can improve their hemodynamics, their organ perfusion will improve as well. That's why we start people on inotropes. That's why we give them fluids. We have this kind of intrinsic bait assumption. And it turns out that early in a shock resuscitation, this is true. If you have a patient who's bleeding to death and you give them blood really quickly, they will perk back up, their cap refill gets better, they'll pink up. But over time in resuscitation, for hours to days, particularly for things like septic shock, changes that we make to somebody's hemodynamics may not actually improve their organ perfusion. And there's a couple of different mechanisms for this. Some of it's just intrinsic to endothelial dysfunction, inflammation, microthrombi that we see in septic shock. But some of this may actually be related to the resuscitation that we do, particularly causing edema and venous congestion. Because for blood to go through a capillary bed, it needs to be able to go through these really, really tight sphincters. And if you have edema and if you have venous congestion, the interstitial pressure increases. And when it increases, it prevents blood from going through the capillaries, and instead it shunts it through these arteriovenous shunts that happen in our tissue beds. So actually, the blood is still going from arterial system to venous system, just not actually through the capillaries, through these bigger vessels that are bypassing the capillary beds that we're trying to perfuse. And so this is termed hemodynamic incoherence, where you could improve somebody's cardiac output and improve their MAP and improve all these things that should be improving their organ perfusion, but we're not seeing it at the organ level. And for any of us in the ICU, we see this all the time. These patients that you're like, why aren't they getting better? I've optimized their MAP. Their cardiac output looks great. I have source control on them, yet they have persistent and progressive organ failure. Many of these patients are hemodynamically incoherent. And hemodynamic incoherence is something that only now we're starting to figure out how can we actually treat this, but it's probably more about prevention. And one of the biggest modifiable factors for hemodynamic incoherence is volume overload and venous congestion, which is one of the reasons why I think this has become more forefront in my mind as I resuscitate patients, is to prevent these complications from happening. All right, so that was a lot on microcirculatory kind of assessment. I'm going to pause here and just see, does anyone have any questions about microcirculation? Feel free to hop on the chat or put a question in the Q&A, or anyone kind of in the room here. My audience has tripled from 1 to 3, so. All right, sweet. All right, so we talked a little bit about fluid tolerance, which the idea behind fluid tolerance is what are the potential harms of IV fluids? And I think of this as the acute illness determines how fluid tolerant somebody is. For example, somebody with acute heart failure, I don't even think that fluids would be beneficial because so clearly it's going to be harmful. Somebody's chronic comorbidities influences the likelihood that they're fluid tolerant. And then venous congestion, or right-sided venous congestion in particular, may impact somebody's fluid tolerance. And venous congestion really comes down to the concept of perfusion pressures. And in the ICU, we talk a lot about cerebral perfusion pressures, the MAP minus the intracranial pressure. And it recognizes the fact that for perfusion to happen across an organ, you have an inflow pressure and an outflow pressure. And the difference between the two correlates to the amount of perfusion that an organ gets. Well, it turns out for things like the kidney, we can kind of think of that as MAP minus central venous pressure as a rough kind of estimate here. And we know that patients who have reduced renal perfusion pressures have worse renal outcomes. Across critically ill patients with sepsis, for example, elevated central venous pressure is independently associated with acute kidney injury. But it turns out for the individual patient in front of you, the sensitivity and specificity for central venous pressure to predict acute kidney injury is actually quite poor. And there's a few factors. One is that the pressure at the right atrium may be very different than the pressure at the end organ. Some patients actually may require elevated pressure to maintain a forward flow. Think about a patient with pulmonary hypertension, for example, that when you drop their CVP, they actually drop their forward flow, and then that worsens their shock. And then also there's probably a bigger question here about whether pressure is the right thing to measure or whether flow is more important. And that's ultimately what I think it more so comes down to, that pressure abnormalities sometimes will result in changes to flow at the organ level, but sometimes they won't. And sometimes the flow abnormality may not be impacted. And so this is why Doppler ultrasound has really become the gold standard for assessing organ level congestion. The reason why is you can actually measure flow at the organ level. So instead of trying to extrapolate, all right, my CVP is 12, is that causing congestion at the kidney? You just go to the kidney itself, you put the Doppler on there, and you see whether or not whatever is going on in the circulation is causing congestion at the kidney level. And why I say enter the Doppler era is that really in the last kind of 8 to 10 years, this approach has become popular. But venous congestion, I really want to emphasize, is not a new physiologic concept. I mean, we've all learned about this in medical school from a left-sided circulation with pulmonary edema. But even the right-sided circulation, we've known this for actually about 100 years now. And so this was an early study where they took dogs and they inflated balloons in the renal veins of dogs. And what they found was that if you increase the venous pressure by 10 millimeters of mercury, that had the same impact on GFR and urine output as decreasing the MAP by the same amount. And so in our ICU, when the MAP goes from 65 to 60 to 55 to 50, we immediately escalate pressures to protect that renal perfusion pressure. Yet when the CVP goes from 5 to 8 to 10 to 15, we might not even notice that the patient's had that increase in venous pressure. Yet arguably that would have the same impact on renal perfusion. And this has been shown in humans as well, where this was a simulated kind of intra-abdominal hypertension model where the pressure was kind of inflated in the abdomen, simulate elevated venous pressure, and very acutely you see a drop in GFR essentially when the pressure is inflated. And so the Doppler era really showed that markers like portal vein pulsatility are more predictive of acute kidney injury than CVP alone. And there's been prospective studies, retrospective studies in the cardiac surgical population, the general ICU population, and specifically John Besmaggi and I have looked at it at septic shock locally and also as part of an international study looking at this. And high venous pressures, venous congestion detected by ultrasound is associated with organ failure for critically ill patients, including septic shock. And we know that pretty definitively now. What to do about it? Now that's a different discussion, but definitely the associations there. And this led to something that many of you may have heard of called the VEXUS score. I think the reason why the VEXUS score really caught on was it's just a very sexy name to say, VEXUS. People love talking about VEXUS, more so than anything else, I think. But the idea was if one of these Doppler markers like portal vein pulsatility or hepatic vein pulsatility predicts acute kidney injury and organ failure, if we combine a bunch of them, maybe that will perform even better. Because sometimes the hepatic vein is abnormal, but the rest of them are normal. Sometimes the renal vein is normal, but the other ones are abnormal. So the idea was if we combine multiple ones, do we kind of round out the edge cases and give us a bit better performance? And it turns out we actually do. And so VEXUS is a better predictor of acute kidney injury than central venous pressure, for example. And so question immediately comes up, like what actually causes venous congestion? It's not volume overload. That was one of the kind of first slides here. And what I would say is venous congestion, you can kind of think of like pulmonary edema on the left side because it's just congestion on the right side. And so there's two things that kind of go into a patient's developing pulmonary edema. One is having a cardiac substrate to develop pulmonary edema. So like low EF, valvular problems, diastolic dysfunction, something that would make it so that they can develop pulmonary edema. And then the second is the acute like loading condition. So if you give a patient with EF of 5%, 5 liters of fluid, they go into flash pulmonary edema. But that same patient, if they did not have that fluid or if they were appropriately diuresed, could be walking outside on the street, not in any pulmonary edema at all. So it's not the EF alone, it's not the volume alone that they get, it's how those two interplay. And so patients, similarly on the right side, with acute RV failure, chronic pulmonary hypertension, chronic tricuspid regurgitation, for example, are more prone to developing congestion if the acute illness or acute fluid resuscitation causes it. So I'll pause there for a second. Any questions about venous congestion at all?
So, Ross, there's 2 questions in the chat. I'll start with the first one. Have you seen hemodynamic incoherence more in one type of shock versus another? Example is septic versus cardiogenic.
Great question. So it has been described in both populations. I'd say anecdotally, I see it more in septic shock, but I think that may just be that septic shock is more common than cardiogenic shock. But it is described in both of those populations, but most of the research into it has been in the septic shock literature. And and there's some interesting ways to assess for it. So one idea is you can do essentially a passive leg raise and check capillary refill time pre and post. So if you demonstrate with a passive leg raise that the cardiac output increases, yet the cap refill doesn't respond to that, that could be a hemodynamically incoherent patient. So,
okay. And then the second question is there recommendations to prevent AV shunting?
Oh, yeah. So, and just to go back to that, so the concept of AV shunting in hemodynamic incoherence is that normally blood should pass through our capillaries into our tissue beds. That's normal. That's healthy. However, when you have a patient who becomes hemodynamically incoherent, what's seen at like a very microcirculatory level is that blood stops going through capillaries and starts going through these kind of arterioles and little venules that bypass the capillary beds. And one of the mechanisms for that is that you actually get edema in the tissue. And when the interstitial pressures go up, it starts kind of like blocking the blood flow through the tight capillaries, and it starts going through the lower resistant arteriovenous shunts. And that causes essentially hemodynamic incoherence. So the first thing that we think, and of course this is all conjecture because it's not a very well yet studied concept, but the first thing is prevention. So preventing kind of gross volume overload in patients may be beneficial. And there's a thought, although certainly not supported by high quality evidence, that perhaps even like ultrafiltration, if these patients are highly edematous, could improve hemodynamic coherence. I don't want to say like the plural of anecdote is not data, but certainly I have seen patients that are hemodynamically incoherent that when you remove fluid for a couple of days on CRRT, their hemodynamic coherence improves, but maybe their septic shock was also just getting better too.
Okay, great.
All right. So just going back to venous congestion for one sec. So I said venous congestion is not volume overload. It's the interplay between somebody's kind of heart and their preload condition. So somebody with a really bad heart that gets a bit of fluid, they could develop severe venous congestion. Somebody who has a really normal heart could get lots of fluid and they don't have any venous congestion. And so there's a lot of things from the heart perspective. So systolic diastolic dysfunction, pulmonary pressures, pericardial diseases. We have a couple case reports, one of them showing that a patient with a big pericardial effusion but no tamponade with renal failure, severe venous congestion, good forward flow. We did, the team did a pericardiocentesis on it, drained the pericardial effusion, almost immediate improvement in the venous congestion, but no change in the forward flow. So pericardial effusions that are large can actually contribute to organ failure through venous congestion. Similarly, tricuspid regurgitation, which is fascinating. Severe TR can cause severe venous congestion that is completely refractory to diuresis, and the only fix to it is really when you fix the tricuspid valve, you can have dramatic improvement in tricuspid or in venous congestion. It turns out that the pulmonary pressures that the patient experiences also impacts venous congestion. So if you go from 5 to 10 to 15 to 20 of PEEP on a patient and you over-distend them, you can actually cause worsening renal congestion because the high thoracic pressure acts as impaired venous return and causes organ level congestion. And also large pleural effusions can cause renal failure and venous congestion. So we have a great case of a patient with a large right-sided pleural effusion, severe renal failure, severe venous congestion. We put in a pigtail, drained off like 2.5 liters, and within about 30 minutes, the urine output picked up, and also their venous congestion at the kidney level improved. Because again, that big pleural effusion was impairing venous return. How much fluid we give people may influence their ability to develop congestion. Although I would conjecture that right now, if you gave me 10 liters of fluid while I was giving this talk, apart from the fact I would have to run to the washroom like 6 times, I probably would not. I'm assuming I have normal cardiac function at baseline, but that may be an assumption. But assuming that I don't have cardiomyopathy, I presume that I would not manifest severe venous congestion because I would be able to accommodate that, mobilize that fluid, and it would not actually back up into my kidneys. And then the last thing is actually local pressures can cause venous congestion. So intra-abdominal hypertension causes venous congestion at the kidney level. Direct renal edema or compression. So we had this one case of a patient with severe unilateral venous congestion, and it was from a retroperitoneal hematoma that was actually pressing up on the kidney and impairing venous return. And then IVC stenosis, which we saw after a liver transplant, where a patient developed profound renal failure of unclear etiology. And on the TE, we saw a massive thrombus sitting at the IVC anastomosis, causing severe lower extremity venous congestion. So they came in, they did a quick thrombectomy on it, and immediately the kidneys started pouring out urine and recovered. And so I really want to just emphasize that high venous pressure causes organ failure. We know that, and we've known about that for close to 100 years. How to treat it depends on what the underlying cause is. And I think only now are we really understanding what the optimal approaches to treating congestive organ injury are. And that's going to depend on the population and the underlying cause. All right, we're almost done, I promise. How much time we got here? All right. So microcirculation, we're going to start with the microcirculatory assessment because all of us right now are fluid tolerant and fluid responsive, but none of us need IV fluids. So restrict these aggressive attempts at resuscitation patients who actually have end organ hypoperfusion. Ask yourself, will this patient be harmed by IV fluids? So what's their acute illness, chronic comorbidities, and do they have venous congestion? And then finally, we can start asking ourselves questions like, what is their cardiac output, stroke volume? Are they fluid responsive? Yes and no. So this was the definition of fluid responsiveness that we used. The reason why I kind of want to skip over fluid responsiveness is I feel like this was a concept that was very popular like 10 to 15 years ago. In fact, it was the sexiest thing when ultrasound came out. Hey, how can we push more fluids into people because that'll increase their cardiac output and that'll improve outcomes? The reason why I don't love it is one, most of the fluid responsiveness literature has not shown improvement in outcomes for patients. But the second thing is I like to think of it more like that preload responsiveness. And the reason why I say that is mean systemic filling pressure had the two components, the amount of volume or fluid in the stress compartment, but also the tone of the vessels. And so theoretically, you could increase forward flow by increasing mean systemic filling pressure in either way. And this is how I kind of explain IV fluids to people is, it's like giving a fluid bolus is a little bit like tapping your credit card at a bar. And so certainly we were all med students at one point, or if not, we've all been to the bar and bought drinks for people. And you go there one night and you want to buy tequila shots or beers, whatever your thing is for your friends. And so you're like, hey, I got this round, no problem. So you tap your credit card and everyone beers and everyone's all happy. And then the next night you go out again and you're like, oh, let me grab this round again. You tap your credit card again, and you go out the next night and the next night. So first of all, you realize you have a drinking problem. But the second thing is you realize at some point that you have to pay off your credit card bill that you've accumulated with interest, potentially, if you don't pay it back in time. And so undoubtedly tapping your credit card works to pay for the drinks, and undoubtedly giving a fluid bolus works to increase mean systemic filling pressure, but you have to pay off that debt at some point. And so my thought is always, if I can increase somebody's cardiac output by increasing their mean systemic filling pressure, by giving vasopressors that recruit the venous capacitance, they take that volume that's in the unstressed compartment, they move into the stress compartment, and I don't have to pay off that fluid overload down the road, that is probably a good thing. Now, for most patients in the ICU, it doesn't actually matter. If you have a patient with a septic stone, they're going to be sick for 12 to 24 hours while their acute sepsis resolves. So it doesn't matter whether you give them a few liters of fluid or you put them on vasopressors early. And that's why most of the studies that look at early versus late vasopressor use in septic shock don't show a benefit, because for 80% of patients, it really doesn't matter. Do whatever you want. But for those patients who are going to be critically ill for longer, for those patients who are less fluid tolerant, it may actually make a difference how much fluid we give to them. And so my default approach is, if I can accomplish improved forward flow, improved stroke volume just through recruiting more venous kind of capacitance, to do that. Otherwise, fluids also work very well for it, but you have to pay them off at some point. And we know that volume overload may be contributing to hemodynamic coherence down the road days later, for example. And so it's humbling to actually look at the fluid responsiveness rates in septic shock. And so after about 8 hours resuscitation, this was Andromeda Shock 1 data, only about, I think it was about 15% of patients, 10 to 15% are still fluid responsive after 8 hours of resuscitation in septic shock. And then in the ICU, if you just take all comers in the ICU, most patients, about 2/3 of patients, are not fluid responsive. So only about 1/3 of patients at any given time. Yet I think when we get called about low urine output, transient hypotension, for many of us, our default reaction is to give them fluids. But statistically, only about 1/3 of patients are actually fluid responsive. And out of those, some of those might have been able to respond just to a little bit of vasopressors as well. In the ED, and this was in patients that actually we suspect that the emergency doctor who was treating the patient suspected had hypovolemia, about 1/3 of them were not fluid responsive. That was like the worst way to say that. So in hypotensive ED patients, 30% of patients are not fluid responsive. 70% are fluid responsive. But that's in patients who we suspect are hypovolemic. So even then, people are wrong about 1/3 of the time. And so just going back to this concept that hypovolemic shock, when I think of it in the ICU, most of our patients, if they're not bleeding, are not truly hypovolemic. The volume may be distributed in the wrong compartment. It may be in the unstressed compartment. And so we want to improve the amount of volume in the stress compartment. There's two ways to do that. You can give them more fluid, or we can potentially try to recruit that with a vasopressor, for example, that'll squeeze the venous capacitance vessels, recruit that blood into the stressed compartment, and hopefully improve stroke volume. All right. I think that if you over-rotate on fluid responsiveness, you may cause harm. First of all, being fluid responsive is a healthy physiologic state. All of us right now are fluid responsive, and that's a good thing. Another way of thinking about fluid unresponsiveness is just heart failure. So we don't want to give fluids until our patient's actually in heart failure, because then we're just going to be causing harm when there's probably marginal benefit for those patients. You can actually be fluid responsive and congested at the same time. And there was a very interesting study that looked at that, and actually fluid responsiveness and congestion overlap quite significantly. And I would just say that if you give fluids to a patient who's fluid unresponsive, that is almost certainly the wrong move. The only reason conceptually to give fluids is this cascade. You have a patient who has low stroke volume or low forward flow, and we're going to give them fluid bolus with the hope that we will then increase their forward flow, and that we hope that that forward flow increase will improve their organ perfusion. So if they're not fluid responsive, giving them a fluid bolus can have no conceivable benefit to them. It will potentially increase venous congestion and cause organ failure that way. It'll cause peripheral edema, but it will not achieve our goal of improving organ perfusion if they're not fluid responsive. So I take the lack of fluid responsiveness as a reason to not give fluids. So going back to this patient, they have septic shock, they've gone 3 liters of fluids, more fluids or vasopressors. Some of the things I'd want to know is, are they still hypoperfused? Yes, they're hypotensive, but what is their end organ perfusion? So I would use something like cap refill. If their cap refill was abnormal, I'd say, okay, how fluid tolerant is this patient? All right, they maybe have a chronic history of CKD, they have a low EF at baseline, and they have pneumonia, which unfortunately is not a very fluid tolerant condition because those patients are at high risk of kind of ARDS and complications that way. So not the most fluid response or fluid tolerant. And then I would say, if I really wanted to try more fluid, I'd say, is this patient fluid responsive? And if they're not fluid responsive, put them on vasopressors. If they are, you still have to weigh the risks and benefits of tapping that credit card versus just putting them on vasopressors at that point. And so with that, feel free to reach out to me on Twitter, X, email. And if you're interested in learning more about these concepts in a lot more detail, we have a website, HCP Rounds, where we talk about hemodynamics, congestion, perfusion, and we cover actually a lot of these topics with the original investigators of a lot of these studies. So feel free to take a look at those videos, and looking forward to any questions.
Amazing, Ross. Thank you so much. That was a really
There's
cool
5 people here now, and all of them clapped. I just want to throw that out there.
It was thunderous applause, at least over the mic. We do have a question by Dr. Paul Cameron here, and then I have my own that I want to ask, but we'll start with Paul's here. So can capillary refill always be normalized? Normal lactate, oliguria, septic shock, but CRT is 5 seconds. Are they perfused enough? Should things continue to be escalated until CRT is normal? And can elevated capillary refill time just take time to resolve when the correct strategy is employed?
Yeah, great question. So I'll just maybe reframe it. So can we always normalize capillary refill time? The short answer is no. There's some patients who, despite all your resuscitation efforts, will always have an abnormal capillary refill time. But the question that I have for that is that because we don't have a treatment for it, or because they're hemodynamically incoherent? And it's slightly different. So a good example is, you have a patient who has a bad capillary refill time and septic shock, but they have underlying severe venous congestion. You've identified that they have congestion. You've stopped giving them fluids. You've started them on an inotrope to address their RV failure that they have, but they still have venous congestion and their capillary refill time is still bad. That capillary refill time may never recover until their underlying congestion and all the different kind of interfaces of their hemodynamics improve. And that can take hours, that can take days. And so if you've identified what you think the cause of it is and you're treating it, there may be no more that you can do to normalize it. But that's different than a patient who you've actually identified, like, I've tried to fix everything I can here, and despite everything I've tried to address, their capillary refill is still horrible. That patient may just be a hemodynamically incoherent patient, where their abnormal capillary refill time is a problem with their microcirculation, as opposed to some systemic variable that you can still modify. And I think the wrong answer in those patients is to recurrently give them fluid boluses to try to improve their cardiac output or their forward flow or their cap refill time even more. Because in those patients, it may be the interstitial edema that's actually contributing to hemodynamic incoherence. If a patient's hemodynamically if a patient's hemodynamically coherent, so changes to macrocirculation should result in changes in microcirculation, and you give them a fluid bolus, you start an inotrope, you give them a MAP challenge where you go from a MAP of 60 to a MAP of 80, for example, cap refill time should respond within 5 to 15 minutes. By 30 minutes, certainly, if there's an improvement in their microcirculation, you should be able to see it through their cap refill. And that's supported by observational data, but then also the approach in Andromeda Shock 2.
Thank you. My question is more to do from a system standpoint. I see you, Rob. I'll get to you after my question. So my thinking is, I drank the Kool-Aid on this. I really believe that we are doing harm by giving too much fluids, but this would be a pretty big systems change in how we currently operationalize things in hospital, right? People get 2-3 liters until they're on some oxygen, and then it's considered to start them on vasopressors and bring them to the ICU. With this thinking that maybe patients are going to improve more or have better outcomes with earlier possibly vasopressor use or not as much fluids, we might be admitting patients to the ICU more. How do you see this from a system standpoint with, already critical care needs across the province and country at pretty high limitations?
Yeah, great question. I've kind of two thoughts on this. So the first is that I actually don't think that earlier vasopressors at a systems level will improve this. I think it's not a systems level issue. It's actually an issue with the individual patient in front of us. And so for most patients, their trajectory of whether they're going to go get fluids or vasopressors is probably like pretty set, and modifying it probably won't make too much of a difference. Like they're not sick enough that it really matters. So whether you give them 2 liters or 5 liters of fluid probably doesn't matter. Or they're so sick that, again, giving them 2 liters or 5 liters of fluid probably doesn't matter. So it's a little bit of a narrow window of patients where this really matters. And so I think the first thing is actually just like identifying the patients where this does matter. And these are patients who are fluid intolerant, and who have bad microcirculatory function. And I think assessing those patients early, not just from a fluid or vasopressor, but phenotyping their shock early is where like a lot of the benefit comes from. So making sure that we're not treating acute RV failure with IV fluids or vasopressors, because neither of which are kind of appropriate for that. The second thing with the ICU capability, which I struggle with a little bit, is just the vasopressors only being restricted to the ICU. I think this is just something that needs to change in a healthcare system. Like one of my good friends works in Mexico City as a nephrologist, and on the ward, anyone can order vasopressors on patients. Like that's just like standard practice in most of Mexico, that like they're not an ICU restricted thing. And obviously somebody with profound RV failure and hemodynamic collapse and instability still needs to come to the ICU. But if it's literally just to protect a little bit of MAP and vasoplegia, you just run vasopressors on the patient, and it's just not a big deal. And so I wonder whether or not we need to just rethink the role of vasopressors in the like stable-ish patient who just needs a little bit for 12 hours of kind of blood pressure support. So that'd be my kind of comment on that. Or just increasing level 2 capacity, or I don't know, there's a good oral vasopressor we can use maybe one day. Rob.
I have no idea why I can't get my camera to work. Is that a thing in the meeting? Am I blocked from cameras here?
No, I think it's just yours, Rob.
Oh my gosh, what am I going to do in my life? Hey, listen, it's really great to see everybody again, Anton and Ross and Eric especially. I missed the first half of the thing. I was in another meeting, Ross, so sorry if you covered this, but can you just talk as a person that in my world with a very like educational lens, how easy is it to teach this sort of stuff, right? Because I think congestion is such a hot topic now. I want to know like how do we teach it? When do we teach it? Who is the best target audience? How hard is it? Compare it to like basic or advanced sonography. Like, can you give me like just a little bit of a TED talk on that? Like a mini TED talk, a Theo
Yeah, great
talk?
question. So I'll just repeat it here because it was a little bit quiet locally. So like how easy or hard is it to teach these hemodynamic concepts, specifically congestion, but I'll answer maybe a bit more broadly. So the first thing is we have empiric evidence that teaching a microcirculation first approach is feasible and scalable. Andromeda Shock 2 was a study done in many kind of low, middle income and developed, but low, middle income and developed countries worldwide, a couple hundred centers with excellent protocol adherence. Cap refill time is something that we can teach med students. It takes very little um, kind of conceptual or technical feasibility. And the Andromeda Shock 2 protocol that uses capillary refill and microcirculation first resuscitation relies on really common, easy things like pulse pressure, diastolic blood pressure, pulse pressure variation on the art line, quick echoes to look for LV and RV failure, like quick POCUSes. It isn't relying on very, very complex measurements or hemodynamic assessments to make really impactful decisions and potentially improve outcomes. So I would say that in my mind, this should be the standard approach that we're teaching everyone when we teach them how to manage shock, which is typically in their intern year when they're just kind of learning on the ICU rotation and emerge rotations. I think this approach generalizes well to ward patients who are acutely unstable. And I think overall, just adopting this idea that if the microcirculation is normal, stop doing things like giving fluid or anything really, just like let the patient exist in a normal, healthy physiologic state. So that would be my comment of when we should talk about that broadly. Going into venous congestion is maybe a little bit more complicated and nuanced. And the reason why is that doing Doppler ultrasound to assess for congestion is definitely feasible. And as part of Andromeda Vexus, we taught centers around the world that had POCUS training, but no specific Doppler training. And they were able to do really, really high quality venous congestion scans as part of our study. But it is hard and it is time consuming. And I don't think for the most part it's super high yield as part of routine assessment if you're only giving fluids to people who have impaired microcirculation and who are fluid responsive. Because if you kind of filter for those two, you probably don't need to assess for congestion that much. Or you could rely on other surrogates, high CVP, high JVP. And I think that would get you 80% of the way there. So I think things like venous congestion should be restricted more to kind of senior resident level, ICU fellow level, where you've mastered the basic hemodynamic concepts and you're looking to layer on something else. I think it's probably a little bit too much to expect people who are also grasping with all the other aspects of resuscitating shock to also kind of layer that on, at least from the get-go. But maybe that'll change over time. That would be my thought.
No, I like that there's a layering in of this on top of every layer across the spectrum of shock teaching, but then maybe the individual sort of like what you taught during Vexus Andromeda is kind of can be thought of in the same area as advanced POCUS skills, advanced like hemodynamics POCUS skills. That's nice. Also,
I kind of think of it like VTI.
Unplugging and plugging my camera back in was the key. That solves all problems.
Exactly.
I think that's a great point. Great question, Rob. I think one of the things that in my relatively short career, but even teaching the juniors in the ICU last week amazes me is the capacity of junior learners to learn things when they don't have to unlearn things. So like I think that if we teach people that the goal is to optimize someone's microcirculation and their tissue perfusion, and that 6 liters of fluid is not the gateway to the ICU the way I had to unlearn, because that's when I started training. That was like you had to give 6 liters of fluid before you called the ICU reach team. I think we'll be relatively amazed how quickly they just go, yeah, of course you wouldn't do that. Because it's hard once you're in practice to realize how easy it is to learn something when you don't have to unlearn something else.
Yeah, I like that point.
All right, we have one more question in the chat. This is our particular case question from St. Thomas. So thanks for the great presentation, Ross. Is there a time when you've identified a patient in shock who is a fluid responder that you've started ionotropes to improve their RV dysfunction, started pressors to improve their MAP, but the patient is still hypotensive and there's ongoing evidence of venous congestion? The question is, would you give Lasix to this patient to try and deal with their venous congestion in this setting, and assuming there's no other reasons to give Lasix like pleural effusions, ascites, fluid non-responder. There's a correction, fluid non-responder. Yeah, that's the question.
Yeah, that's such a great and hard question. So just to maybe summarize it, so you have a patient with acute RV failure who you're trying to optimize with inotropes and vasopressors, and despite that, they're like still kind of borderline hypotensive. The RV is not looking great, and they still have severe venous congestion and they have organ failure as a result of it. So you're trying to figure out how to prioritize management. So I think in these patients, I asked myself first, like, what is the etiology of venous congestion and what is the etiology of RV failure? Because those are both hyper relevant. And so the reason why I say what is the etiology of venous congestion, even though there's severe RV failure, is that tricuspid regurgitation.
Did we lose him?
Yeah, Ross froze on my screen.
Okay, we'll give a minute. I guess I'll take this minute for everyone else on the chat to announce our next SWOCCS date. We have our next presentation by Doctors Henry Eisenberg from Hamilton General Hospital and Dr. Carter Winberg for March 19th, 2026, and we'll be presenting at noon Eastern Time. And given their expertise in ethics and their educational portfolio there, they'll be presenting on ethical decision-making in the ICU, which should be a really great topic. I think affects us all, and we hope you can all join us for that. I can't tell if Ross is controlling this. Or this is Eric's screen. Okay. So I think we lost Dr. Prager there. But thank you, everyone, for joining. It's unfortunate. If you do have other questions for Dr. Prager, send us an email or Dr. Prager himself. He had it up earlier. And Eric, if you can go to the next slide, that's the emails for the SWOCCS team. And please, we also left our Google form in the Q&A. If you do have questions or if you want to present, we do want to do more case rounds with sites throughout the Southwestern Ontario region and would love to have more people included. So please reach out to us. We're very open.
I'm back, Anton.
Perfect. Okay.
All right. Sorry. I have this auto bot set up that every time I get asked a question that's challenging, it just automatically disconnects the Zoom. So it gives me like another 30 seconds to think about the answer. So thank God I had that set up. So that's a really good question. So essentially, just to rephrase it one more time here. So essentially, you have a patient with acute RV failure who is on vasopressors and inotropes. They're still hypotensive, but they still have severe venous congestion and organ failure. So the question is, would you ever diurese them? And the two things I think about are first, what is the etiology of venous congestion and what's the etiology of RV failure, because that'll help indicate it. So if you have a patient with severe venous congestion and RV failure, there's actually a couple different mechanisms by which they can have venous congestion. Of course, RV failure itself is highly associated with venous congestion. The amount of fluid and volume overload can contribute to venous congestion, but also the status of the tricuspid valve. And so if you have functional tricuspid regurgitation that's severe, very interestingly, unless you improve the severity of TR, you will not improve their venous congestion. And this was shown by a buddy of mine, Eduardo Arguez, in a cool study where he took patients that had severe, what they thought was primary tricuspid regurgitation as an outpatient. He's a nephrologist and chronic kidney disease. And what they would do is they'd bring them into clinic and diurese people until they couldn't walk into clinic anymore. And that was like until they were like so pre-syncopal that they had to say stop. At that point, they then reassessed the venous congestion, and they found some interesting things. So the first is that patients with severe primary tricuspid regurg, none of their congestion got better with diuresis. Like literally, like you could diurese them until they couldn't walk anymore, and they still had severe venous congestion. What they would do is they would send those patients for a tricuspid clip or for a tricuspid valve repair, and then those patients would actually have complete resolution of their venous congestion and often improvement in their CKD. But one of the really interesting things they found is actually some of these patients that they thought had severe primary tricuspid regurg actually had secondary TR. And with the aggressive diuresis, as the RV architecture got better, their TR severity got better and their venous congestion got better. And so if you think that this is secondary TR or functional TR from RV dilation, theoretically diuresing them could improve the severity of TR and thus improve their venous congestion. So that was the etiology of the venous congestion. And the second is the etiology of the RV failure. If you think that the RV failure is due to high afterload, for example, if they have acute cor pulmonale from being mechanically ventilated, pneumonia, or like a PE, it's unlikely you'll be able to diurese them acutely. And often these patients are less diuretic tolerant than if the etiology of RV is has a normal PA pressure. So that would be something else I would consider. I think that when somebody is very, very sick with acute RV failure, ultrafiltration may be of benefit, but rarely do I see profound improvement in hemodynamics, and often it's a little bit tenuous to get fluid off. We often try this, right, to improve the RV failure and to improve the congestion, but it can often be difficult. And I find that these patients often have like poor diuretic response because of their renal dysfunction. So often these are patients that end up on CRT to optimize the RV function. And we see this often in the cardiac surgery ICU, where you're kind of balancing fluid removal, but kind of intolerance to fluid removals due to RV function. Thank God I had that extra time.
Yeah. Well, thank you again, Ross. I'll leave it for a couple seconds to see if there's any last minute burning questions. See any? Okay. Well, we'll end it there then, guys. Thank you again for joining SWOCCS, and please look out for the meeting on March 19th, Ethical Decision Making in ICU.
Thanks, everyone. Thanks, Ross. Have a great day.